Today, we are on site in Washington, D.C. for Day 2 of the Association of Community Cancer Centers annual meeting and Cancer Center Business Summit. We will be recapping some of the top news presented each day during the meeting, and soon we'll speak with Dr. James Hamrick, Senior Medical Director of Flatiron Health, and Dr. Ali McBride, incoming President of ACCC. Welcome to AJMC On Location. I'm Jamie Rosenberg. The second day of the meeting focused on technology in healthcare and the digital health revolution. There was a session on likely innovations in health IT over the next 18 years based on insights from leaders in government, academia, and industry. In addition, there was a panel discussion on how wearables are generating patient-reported outcomes and empowering providers to be able to better manage symptoms and improve resource utilization. Read about these studies and watch additional interviews from the meeting at ajmc.com. Here with me now is Dr. James Hamrick. Hi, Dr. Hamrick. Thanks so much for being here with us today.
Hi, Jamie. Thanks for having me.
So a big topic at this conference, especially here on Day 2, is the use of and potential of technology in healthcare. And as technology continues to evolve, it's improving patient outcomes. So what new technologies being used in care delivery have the most promise or are currently making the biggest impact for patients and providers?
So I think it's using technology to get the right data and the right information at the right time. So for a little context, during just my oncology career, I trained in the early 2000s, we've seen this explosion of new treatments and therapies. I consider 2001, which is right when I was doing my post-med school training, the beginning of the targeted therapy era with the approval of imatinib for chronic myeloid leukemia. It was the first time we had rationally designed a molecule to fight a specific disease, and it knocked the cover off the ball. After that, we've had this amazing release of targeted therapies, immunotherapies that use the immune system to fight cancer. And that's led to great outcomes for patients. But it's also posed a lot of challenges which technology is helping us address. As a practicing oncologist who sees lots of different cancers, keeping up with all of these new therapies, knowing exactly when to use them, technology can help me by surfacing the right data at the right time. It can help me make the best decision for my patient. In addition, you know, a lot of these therapies are coming out so fast that we don't have the perfect randomized clinical trial that we would want to tell us exactly how to use the therapy. Real world evidence where we actually learn from patients who might not be on a trial, but in whom we can collect really high quality data can help inform, you know, if I have a patient in my clinic that might not have qualified for the trial because maybe they had a heart condition, can I still safely use that medication? So being able to actually leverage that data from the real world so that we know when to use these amazing new therapies and how to use them safely is a huge advance, and technology is really leading the way. The tooling created by technology is letting us take better care of patients.
Great. And so how well are clinicians and practices integrating new technologies into their care delivery?
I think they're doing a great job. So we have a unique window at Flatiron with seeing how care is being delivered across the country, because we have, within our network, we have small 1 to 2 doc practices, we have very large practices, we also integrate with large academic centers and health systems. So we get a good real-time snapshot of what's going on. We are able to see uptake of new things like diagnostics, so comprehensive genomic profiling, use of immunotherapies, and what my take on the data is that the new treatments and diagnostics are being used by clinicians both in the community and in the health systems academic settings in a way that's really promising. So that technology is disseminating so patients are getting the best care that they can. And I think that's an incredibly important thing, and technology can continue to assist doctors knowing what the best treatment for their patient is. Now, we also work with teams to integrate new software into their practice day to day, and you know, they're really good sports about it. The key is that you really it has to make sense for their workflow. So if you're developing a new technology, it will be embraced if it helps doctors be more efficient. If it slows people down, then there's going to be resistance, as there should be.
Great. And how is Flatiron working with the FDA to use technology in order to improve this use of real-world evidence for decision making?
We're really excited about 21st Century Cures sort of mandated understanding how to integrate real-world evidence into regulatory decision making. We've had a collaboration with the FDA going back to 2016. It's resulted in a couple of co-published manuscripts. We presented with the FDA last year at ASCO, and that's really important because the framework that the FDA recently released on real-world evidence is something we did public comment on, and we feel like we're really aligned with them on their vision for that. We've just renewed the collaboration, so we're going to continue moving forward, and now it's really about data quality, making sure that everything that we do as far as real-world evidence is done in a very transparent and scientifically rigorous way, so that we can bring new analytics and new applications, such as real-world, synthetic control arms. That's never going to replace the actual control arm on a clinical trial, but it can absolutely augment it and make trials more efficient. So, being aligned with the FDA on the vision for real-world evidence is something that we really want to get right, and we take a lot of pride in at Flatiron.
And so EHRs are both a source of great opportunity, but also pain for clinicians. How is Flatiron working to help providers use their data in a better way and kind of get through some of these barriers or pain points they're facing?
Yeah, so as a practicing oncologist, I know the pain points of using an EHR. It's the 10-year anniversary of the HITECH Act, and that is the legislation that actually got us over the hump in terms of getting everyone from paper to digital, and that's a huge step. So sometimes it can feel frustrating in the day-to-day world. There was a huge article this week that called out some of the challenges, let's say, about EHRs, and I think that was largely on point. However, I'm an optimist. I think if you step back and look at the arc of where we're going, EHR 1.0 was really digitizing a paper chart, turning it into sort of the equivalent of an electronic file cabinet. We're poised at this moment to really begin to use technology to the advantage of patients and doctors. The initial EHRs weren't designed with the doctor-patient interaction in mind. The day that light bulb came on for me, it's like it released a lot of pressure, and I said, now I understand. But I think now, it was sort of forced on clinicians, but now we're not going back to paper. And clinicians and care teams expect high-performing technology that looks like technology in other parts of our life. And I'm excited. We're poised to really turn the computer and the technology into an ally as opposed to an obstacle in caring for patients.
Great. I like the optimism.
Yeah.
And so do you think technology is getting better at letting providers use data in real time at the point of care when making decisions?
Yeah, absolutely. So, it's really important that the technology layer the right data in at the right time. So it's not enough to just say we're going to push this out to everyone with the press of one button. As a clinician, when I'm in clinic, I need to have the appropriate technology surfaced to me at the right time. So, one of the big challenges is how do you make documentation flow as a byproduct of taking care of a patient and having a conversation like we are, as opposed to driving the process. So one of the things that we're working on at Flatiron are strategies to help providers have the documentation flow. So for instance, when you see a new patient, one of the most important things to do is to capture the key data about their disease. So the diagnosis, the stage, the biomarkers that are going to help you make that treatment plan. In the workflow that we've designed, we sort of redesigned it based on feedback we got from providers so that they can quickly capture all of those elements, all of the newest biomarkers, and then they're there in the EHR for good, so they can be used as decision points for treatment, they can be used for matching for clinical trials, which is another challenge, they can be used for succeeding on quality programs and payment programs. And so that's an easy early win. I think we're gonna get smarter about having the right sort of decision support or assisted technology to help make the best decision for that patient at the right time.
Great, and now looking toward the future, where do you think we'll be with EHRs in, say, 5 to 10 years? Do you think the things we're talking about now will become a reality, or some of these pain points will still kind of be there?
I do. I mean, look, some pain points will always be there, but I'm an optimist. I think in 5 to 10 years, it's gonna, the computer or the mobile device or whatever is with us in the exam room is gonna feel a lot less present. And so as opposed to being a distraction from the doctor-patient interaction, I think it's just going to be there, paying attention and nudging when we need, some piece of key information. Hey, by the way, there's a clinical trial for this patient that's open at your center. You might want to think about that. Nudging me as the doctor right at that point where I'm making the treatment decision in time to act on that. and yet it's not going to be intrusive. So I'm an optimist. I think that we are going to get to a point where the technology, again, is a real ally as opposed to an obstacle.
Perfect. It was good to end on a good note. Thank you so much for joining us today.
Thanks, Jamie. Thanks for having me. Great.
Next up with me, I have Ali McBride. First, congratulations on being the new president of ACCC, and thank you so much for being here with us today.
No, thank you for taking your time today. Pleasure to be here.
Perfect. So to start off, this morning you had a session about biosimilars. What role do you see these drugs playing in the oncology space as more of them hit the market?
You know, I think the main topic of discussion over the last 5 or 10 years has been the cost of therapies. We've seen costs of drug therapies rise, increased discussions about patients who don't have access to these therapies. Even talking on the non-oncology space, just with insulin, you're hearing more and more patients talk about the rationing of drugs, rationing of insulin, because they can't afford these copays. So with the advent of discussions on biosimilars, we've really been able to see a change. Slow change at this point because they're very new to this area and space. You know, with the Affordable Care Act, we had the implementation and definition of biosimilars. But in Europe, they've been using it for 10 years. So a lot of what we're seeing with biosimilar implementation is slow, but in 2020, most likely, we will see a large amount of oncology biosimilars hit the market. And we're starting to slowly see approvals garner more and more approvals in these therapies with, you know, about 4 trastuzumab biosimilars right now being approved, multiple pegfilgrastims, which are an actual long-acting growth factor, approved right now. And then we're going to see more in the upcoming years. And actually, as we see more and more competitors into the market, we expect prices to drop. Initially, we had seen a small drop with the first biosimilar being introduced, which was by Sandoz, with Zarzio, filgrastim, Sandoz. But as time has grown, we've seen the prices drop. And many of our practices within ACCC, who are OCM model participants, are utilizing biosimilars to reduce the cost of drugs in their practice. And this really is garnering access for patients across the board. Hopefully within the next year or two, as we see those oncology biosimilars, those therapeutic biosimilars hit the market, we're also going to have an increased access and lower costs for these therapies as well. So hopefully, we expect these prices to drop for those biosimilars, but also the originator products as they actually start competing for prices as well.
Great, good to hear. And how well do oncologists and their teams understand these biosimilars, how trials confirm biosimilarity, and the potential for switching? And so is there still some unawareness and misconceptions that you find?
So that's a lot of questions in one. So I'm like already a little bit stumped, but we're going to do it. We're going to work through this one. So in terms of education, right now we see a lack of understanding of biosimilars. In fact, one of the issues that Scott Gottlieb, the FDA director, had brought up was the fact that we're seeing a lot of misinformation with biosimilars. And just that impact alone is making a lot of us concerned in the healthcare community. So there still needs to be a large amount of education. In fact, we continue to hear from physicians, practitioners, pharmacists, nurses, healthcare workers, that they don't understand the process. So I'd say over probably the next 5 or 10 years, we'll need to do a lot of due diligence to make sure education is provided to healthcare provider and also healthcare provider teams. That not only includes an understanding of how the actual FDA approves biosimilars, how they develop clinical trials, the understanding of extrapolation, but most importantly, the discussing of interchangeability. And this is something that's currently draft guidance right now. We expect to hear something back in May, and that will help us understand the switching components between biosimilars. In hospitals or health systems, we've been doing this for years, but it's called therapeutic interchange. For this biosimilar and also the definition of interchangeability, this will be something new to us, and also how it's defined as well. So there's going to be a large amount of growth, movement in the area from an educational perspective, but also the discussion on reimbursement changes will also go to the financial counselors, financial teams, as they deliver these pieces as well. So we have a lot of time in terms of understanding what to do, in terms of how to educate. And once we educate, we can then deliver these actual informational pieces, these biosimilars to patients, and also intertwine them within our healthcare delivery system as well.
So something you mentioned was education. So if oncologists are not well informed about biosimilars, how are they currently being educated about them and how they're used?
So we see a lot of information coming from different sources. Probably the biggest source right now is educational materials from review articles, published articles, abstracts. We see a lot of information coming out through different areas in the country and also the globe. So mostly coming from educational meetings and major conferences. But we're also having a lot of information being developed from literature, primary or tertiary literature with either review articles or the phase 1 or phase 3 studies. But areas which are still being utilized, I think are going to be expanded here shortly, will be CE activities. And that's going to be a great opportunity for our physicians, but also a lot of our pharmacists, our healthcare team members, our advanced practitioners, and nurses who will actually have information pieces as well. The other part of that, which ACCC has done a fantastic job, is the Financial Advocacy Network. Those people who are working in the financial advocacy section will need to actually have information as well. So it's not just the physician who's prescribing it, it's the actual continuum care, the interdisciplinary members as well. So we'll kind of address that in the short term, and hopefully we'll see more CE participating in this, both for the actual information in regards to how the drug is developed, but also the actual how to get the drug, how to get the patient assistance program out there as well. So it'll be multifactorial, not just the physicians, but the overall healthcare providers across the team.
Great, well thank you so much.
No problem, thank you very much.
That's all from the ACCC Annual Meeting and Cancer Center Business Summit. Join us again April 4th and 5th when we will be reporting on site at the Community Oncology Alliance's Community Oncology Conference being held in Orlando, Florida. Thank you for watching AJMC News Network. I'm Jamie Rosenberg.